Welcome to the next section interview. I am your formerly YPS Young Physician Section, now Early Career Physician Chair, Laurel Barr, and I am here with the Tactical and Law Enforcement Medicine Section and Dr. Keegan Bradley, who is the current chair. Please tell me a little bit about your section and tell me how you got involved.
So my section is primarily dedicated to involvement with physicians, and really we've kind of since expanded out to non-physicians, so paramedics, PAs, anyone involved. We've allowed for non-ACEP members to be part of this, who primarily involve themselves with what had started as more of a military kind of background, but we realized so many of our members were actually more law enforcement involved. So we've expanded out to both those, and that's from all levels, from local police departments all the way up to we have members in charge of some of the federal systems and stuff, DPS, HSI, NTOA, all the alphabet soup of all these big law enforcement departments, both national and international. We've had some speakers come on from the Philippines, South Korea, all sorts of places. So it's a really diverse group. And then my involvement, I guess I almost forgot that part. I started as a resident. I learned about this section even existing once I was probably a second year resident. And I think Dave Calloway was the chair when I finally joined as a member. And it was really neat. Ironically, I went and became his fellow right after that. So I stayed pretty involved with that. And ever since then, he brought me on as an officer, and I've kind of moved up through the ranks up until then. So I'm still also very early in my career, but it's been a really cool group, a neat group.
Another early career physician.
Hmm.
Do you have a law enforcement background, or did you just find this while you were training?
I was initially helping out. I would go out when I was a resident. I went out with Fort Worth Police Department. I'd provide support for them. When I was a fellow, I did it out in Charlotte. And then when I moved back actually to Texas, after my few of my fellowships and finishing up training, I was able to get one more thing by my wife, who had put up with so much of my training and stuff. She allowed me to do one more thing because when I wanted to help where we had moved to out here in Texas, they said you need to go through the police academy to be able to do this. So that was 6 months of 8 to 5 during the week and working every weekend and holiday in the ED after that. So I am a licensed peace officer with that. Not all of our members are, but yes, I do have a law enforcement background as well.
When I went to medical school, I thought that would be the lifelong training. And then you get involved in all these different things and you
I
find
know.
more and more ways to make yourself a well-rounded person.
Yeah, we're very much gluttons for punishment, I think.
Well, I do like this section. I did not know this section was a part of ACEP. I probably scrolled through it a few times, and I'm an EMS director. And what I find that I like about this section is that when I teach my basic EMTs, I say, all right, scene safe. And if they forget to, sometimes I have someone shoot them, metaphorically. But
Yep.
that's the extent of their training in this, is they just say, is the scene safe? And then really, this is your entire a part of medicine is before the scene's safe, when the scene is safe, when the rest of us can get in, who to involve. Uh,
Yes.
and I think that's awesome. And you operate under high threat environments. So tell me a little bit about how it's different under those high threat environments as opposed to when I've got all my resources around me.
Yeah, so this is an interesting niche, some people would call it, but it's a growing space, I'd say, where, I think one of the best parts I love about emergency medicine is we're always trying to bring medicine more to the forefront. Then EMS, like you said, bring that medicine even farther to the forefront, outside the hospital. And this kind of fills that gap, I think, between, like you said, time of injury to when seen safe. Those are vital minutes. I know you know that as an EMS medical director. And the closer you can shorten that time to care down, the more lives you're going to save. And this is kind of one of those instances where you want to get on scene, provide the immediate care that you can, but sometimes it's not usually safe enough to allow formal EMS providers, even these RTF programs, to come onto scene yet because there's either still active shooting or potential for active shooting. So that's where this was kind of born, was people saying, I don't care that there's bullets flying. I still want to go in there and help people. And the military was obviously a big initiator with this because that's the environment they live in day by day. And then they started to take it back to the civilian world and say, hey, why can't we do it here? And since then it's grown. So it's an interesting spot that it gets to fill. And it's really fun to be a part of. I love it.
Well, I don't call many people crazy. Usually patients come in and say that I did that when I never did. But people who go into where things, bullets are flying, I call you crazy.
Yes, yes. I still keep my head very much down. I'm 6'5", so I have to find, big things to hide behind, but it it's still a nerve. Even if there's not a concern about weapons on that scene, you're still very much nervous. You have the adrenaline pumping. You're like, you never know what if.
Well, and just like in the emergency department, the more you prepare, the safer it is and the better the outcomes go. So you
Absolutely.
train under these circumstances and you just be aware of the extra things and plan for the best, and that's what you do.
Absolutely.
So the core mission of the section is to provide evidence-based clinical care, operations, provider safety training through education, resource, and collaboration. Tell me about how you do that.
So we really are a lot more, I'd say, diverse in how we operate. I think most people think, hey, these guys just go out on SWAT calls, and that's not true. That's probably a very small part, especially as of late. I think a lot of the, initial members, that was kind of only thing that they were able to get involved in sometimes, and it's exploded since then. We have all sorts of research that's coming out. SOMA out of North Carolina, the Special Operation Medicine Association. This is what they live for, is the research on this. And it leads to a lot of things that we bring back to the emergency departments, the TXA recommendations, March assessments, all sorts of stuff like that kind of are born from where we live and play. We work with a lot of different groups. One of the best things I've loved since taking over as chair is we've done a lot of co-talks as far as our educational talks with other sections. So we've done, disaster medicine. We'll reach out to flight medicine, ultrasound. We had them come and give a co-talk with us because there's so many kind of unique things, kind of like EMS, that you can bring into that field. And then the political side has been really interesting. I think we try and show people that this is actually a very apolitical group, which I understand if you don't know it and you just see the name. You're like, oh man, they're just all for this or that, and they have one view on something, I'm sure. But it's interesting if you come in and listen to the group discuss things, it's very two-sided, which I like. I like to see both sides of these arguments, and it's been interesting to get involved because, like we talked about, law enforcement very much has the ear of a lot of different levels of government and how it operates. So it's actually a very unique tool that we can kind of use as, our position as physicians with them to help kind of change things for the better in the sense of providing medical care or affecting change that helps a lot more people. Because law enforcement, they get to be on scene, they get to control these things, but they don't really have the knowledge that we can bring to the table to help remind them, hey, what about this or that? And my experience thus far has been they've been very open and very eager to engage with that as much as they can. And, we've been able to do that both nationally, internationally. Um, it's been a really unique opportunity. I didn't expect to take me and the other members as far as we are with a lot of how we're able to engage.
Yeah. Speaking of taking things far, the section was recently asked to present at a conference in South Korea, which sounds like an amazing opportunity. Tell me about that.
Yeah, so that's been one big thing I've been pushing as the section chair is involvement both nationally and internationally with our physicians and members. Um, we've had actually an interesting increase, which I've been really excited about, of international members coming into the group, and that's bore a lot of fruit as far as opportunities to help shape not just the U.S. but other countries. South Korea was the most recent one. Some of our officers were able to go out they were invited by the South Korean government after they had the recent political upheaval where the president had declared martial law after the physician strike. They invited us out to give a talk at it was kind of a conference or convention for a lot of their politicians and government. And a lot of our officers were able to go out and speak in front of them and provide advice, things that we do here, things that they could be doing here. So it was a really cool and unique opportunity for our section to go and get to help shape another country's kind of political approach to how they provide pre-hospital, but also military and operational medicine.
Yeah, what a great experience sharing what we do on the ground to other places where there might be differences, but there might be a whole lot more similarities where we can apply the best evidence-based practices.
Yeah.
Awesome. And I know the section has been involved in creating national guidance for on-scene care and other international presentations as well. One of the things that I think comes from probably this section or this area of medicine, I feel that as a practicing physician, there's not been many things that have changed the way I practice very often. But the Stop the Bleed campaign and the evolution of how we're applying pressure and tourniquets is one of the things that's really advanced since I came into practice. Tell me a little bit about the involvement in the Stop the Bleed campaign and then what we can do to get involved in that.
Yeah, our members are very involved in that group specifically because it applies so much to our environment, whether it's teaching law enforcement, first responders. So, like I said, I will admit, you're an EMS physician, I'm an EMS physician. We like to say everyone's first responder, but when you talk about who's truly usually first on scene for a lot of these things, it usually is the police officers out on patrol. So, a lot of our involvement does go into the patrol officer. I think a lot of people think we're just, guys that like throw on SWAT gear and go out on SWAT calls, but when we've looked at it, the real change is SWAT calls are 2 to 3% of what goes on in the police department and their engagement. It's patrol officers, it's frontline officers. That's where the real engagement we've tried to have and real change we've tried to affect is going on, because they're the ones who apply that tourniquet or they're the ones who apply that pressure. And, on the higher level, the SOMA, a lot of these bigger groups, they're the ones who get to go back and say, look at the evidence of this. Should we be changing how we do things? The tourniquet's no longer right above the wound, all the way up to the top, just for example, different things like that. So they've been able to shape how a lot of trauma care is done out in the field. So Stop the Bleed's been a great partner with that. And then we take it out to the community, even past law enforcement. So one of the things I've been able to do with my sheriff's office, and I know a lot of the other members do very similar things, is they utilize a lot of the resources, the outreach, the communication ability that these law enforcement departments have already, but they use it to affect change with medical, Stop the Bleed, those kinds of things. And it's done a lot of great things. Stop the Bleed's one big one. Our sheriff's office, one of the things I love is twice a year we pair with Special Olympics of Texas. A lot of people with intellectual developmental delay, disability kind of things, Down syndrome, all those. We've set up a police academy day for them. So they get to go through and kind of learn about what law enforcement does. Law enforcement gets to learn about them. And, we have some real conversations with them where we're sitting in there and we give a presentation on how important it's become in the sheriff's office, how to engage with people who have autism or, IDD or something like that, and truly educate them. So when they're coming on scene and they're acting different, it's not a threat. It's just kind of how they respond to things like lights, sirens, those different things. And the kids love it. We always way overmax our list of people wanting to get involved. But we also teach them things like Stop the Bleed and stuff, and they learn it. They know how to do it. So it's exciting. A lot of different, just unique ways we've been able to engage with the community that otherwise it'd be a little tougher too. I think, some of the hospitals you talk to them about that, they're like, yeah, that's fine. Go out, do it, figure it out. But when you have the power to use, EMS, fire, or police and their resources and already being involved in the community, I think you get a lot more bang for your buck.
Yeah, really having those people who respond door to door, showing
Hmm.
up, showing face, meeting members of the community and learning about that thing. And man, we talk about the golden hour of trauma, but if we get that basic life support in chest compression, only CPR,
Yeah,
put some pressure on it, and then we can talk about the golden minutes and how many lives those saves as opposed to all the fancy things we do afterwards.
exactly. Exactly. Yep. That's the things that matter. So, and, I know we had kind of discussed a lot of the engagement with the community, but also the interactions between police and medical providers, stuff on scene. And that's one of the other things our section's really been pushing. I think, again, I worry sometimes people see our section and they just think, well, they're just going to support whatever police want. And that's not really true. I think we're more in the business of trying to help shape how police operate to save the most lives, which is most of those police officers' goals. And the recent shootings and a lot of the Minneapolis unrest kind of brought to light again what a concern some have laid out, where there's still kind of a bridge that needs to be gapped with how medical providers interact with police and how they get on scene and how's the best way to get them to help people when they're hurt or down. And we're working right now with ACEP to try and build out some operational protocols to provide to law enforcement as a tool to help facilitate medical providers on scene. Because I think there's a big, I guess, difference between what a physician running on scene to someone that's been shot wants to do versus what a law enforcement officer now sees. And this protocol we've written up kind of helps try to bridge that gap. So both kind of get to understand what the other is thinking, but it also helps facilitate it in the best way to make it happen. Because, you try and tell one or the other to do something, it won't happen. But if you can provide these options for them that we're working on, that we've taken a lot from the EMS world where it's already functioning very well, we're hoping that this will help kind of facilitate that help. And like we've always talked about, getting that care immediately as fast as we can safely on scene.
So, in non-abstract terms, you are talking about the section's response to recent events in Minneapolis, and specifically when a physician arrives on scene, what the different perspective is between law enforcement and between that physician and their goals, and what the section has done in direct response to that. And you talked about how there has been collaboration. We didn't just go out and say this is what they should have done. We asked our resources, asked the people that we work with, asked our EMS and police providers for their information to go back and inform those policies. That way,
Correct.
because if you tell me as a physician I've got to do something, the first thing I'm going to do is say, no, I'm not going to do it, right?
Yep. Yep.
So if we tell them the same thing, then nothing's going to happen that we want. So you went back and collaborated with all these people that you work with to find the best informed policies for the correct perspective. And now we have a policy that you've given to ACEP. And
Yes. Yeah, I've given them the kind of draft of it after I talked about, as you mentioned, both. I went to our section members and some of our officers, primarily more of our officers, because if I ask the 100+ members, I'm going to get 100+ different opinions and answers. But I kind of kept it with our officers and some of our past officers, and I got also a very diverse answer to them. Some were like, absolutely not, but some were like, I think this is a great idea, and then most importantly, some like, here's some changes. And then I went to the law enforcement departments. I said, hey, I want you to tell me everything you would hate about this or everything you'd find wrong and everything you like about it. And it's since then been kind of formed and morphed to try and find that really good middle ground where I think both sides would consider it very palatable, but also helpful, more importantly. And like you said, it doesn't tell anyone they have to do something. It tells them how they can do something. And that I think is the best approach that I'm hoping ACEP will get behind and support, and then hopefully the law enforcement departments and a lot of the organizations find it as a useful tool to try and move forward. Because I think that's what the community is really wanting too. I think they want the most immediate care on scene to help save the most people. And most law enforcement, any law enforcement that should be doing what they're doing feels the same way.
yeah, and you talked about how they have different priorities and they need to make sure that that person isn't misrepresenting themselves and isn't a threat. And it's true. I don't carry, I mean, if I'm just out in my car, I don't always carry my hospital badge, and I don't have a
Mhm.
medical director card, and I don't remember the way to look it up online in the
Yep.
instant, you know?
Yep.
So they have all those other priorities. And the reason, if you tell me something as a physician to do something and I don't know why, I'm not going to do it, is because I don't know if that's the best way. So
Exactly.
back to those people who are involved in them asking their input and allowing them to have that discretion on the scene, just like we have clinical discretion when we have the patient in front of us, is going to get the best outcome so that everybody uses these in the best way possible. And then we save more lives, which is the ultimate goal.
Exactly, yeah. Because if you ever, I mean, like I said, if someone comes down to the emergency department, tells us, "I know better, you should do this," that's the quickest way for me. I have no, I want no part in this. I had no part in this, so I have no motivation to be a part of this. So that was the one thing I wanted to avoid, and this definitely does not do that. It actually more encourages them to say, "We understand you know what's best from your side. We know what's best from our side, and we're trying to find that middle ground."
Yeah. Great collaboration. And it sounds like still a work in progress, but getting ready for ASAP support so that
Yeah,
we
we're
can
hoping it'll
get
get our
going.
support.
Yeah, and then collaborate with all these other agencies that you're working with. You mentioned you work with chief of police, you work with SWAT teams, you work with tactical law enforcement operations, special operations. So a whole bunch of different organizations that you work closely with to get these policies out to really help everybody.
Absolutely.
All right. Well, two more questions for you. If someone has listened to this and wants to get involved in your agency, you mentioned you got involved as a resident, so ties with EMRA.
Yes.
What can we do to reach out and try and help with all these things?
So Emra is a great resource. They actually have their officers engaged with us is very active. He's got a lot of things going, so that's one route. Directly going on to the website, you know, you can contact through that. We have our section liaison, and then I believe it has. I don't know if it has my direct contact on there, but you know, any way to get a hold of us that way, we'll get you hooked up. And I know we mentioned there's some secret squirrel stuff on there. Don't be intimidated by that. There's nothing, you know, there's not some about aliens or anything in there, but it's just some other content that, you know, we've kept kind of a little closer to the vest. But it's something I think everyone really likes and they get engaged with. So any means, the liaisons are great though. We had George for a while, we have Amber now, and some of our others, they're great. They're on top of it.
Yeah. So get involved, reach out to through the website or through other liaisons through
Yeah.
EMRA.
Or come to our committee meeting at ACEP. It's
Yep, in-person meetings are always probably the best way, especially because you can just walk in and ask. But there is a
absolutely.
section of your website that is for members only that you mentioned we keep a little close to the vest. Can you tell us
Yes.
a preview of what we would expect from that if we join?
Yeah, so it's a lot more similar to some of the things you might expect to see, how to operate, how it just has some more specifics on maybe how some local departments operate that they don't want out in the just complete public, or there's talks on things that, you know, maybe the speaker said, I don't want this just to be able to be put on, you know, Monday morning news kind of thing. So we try and keep it a little secure. Is it, you know, absolutely, you know, lock and key protected from anything? No. But we just wanted to kind of make a little bit more of an effort to respect the people that are willing to put kind of a little more out there that they normally wouldn't put out in the public. So it's some good talks, but it's, you know, it's like I said, it gives more specifics on how some places operate that I think people would find really interesting to get to see. But that was the reason for that.
Yeah, so a little more technicalities once you get into the weeds.
Yeah, yeah, stuff with a little more operational security. They preferred to just not have open to the world because anyone can jump on to ACEP's website that's not even an ACEP member and scan through all the sections. This is just to say, hey, are you a member? It just makes one little more effort. So just the random person that would have to make that effort to get by there is not really going to do.
Yeah. All right. Well, thank you so much for taking the time to talk to me. Sounds like a great area of medicine, lots of collaboration between different organizations that really the House of Medicine doesn't always interact with. And that's what I love about emergency. We got our fingers in everything and you can
Absolutely.
really make this anything that you want. So thank you so much for taking the time and good luck with that baby.
I appreciate it. Thank you for talking to us today.
All right. Thank you.